In the question, it is given palpable purpura seen in this patient. Here you are able to see bilaterally over both the ankles and also lower one third of the leg is having a palpable purpura. If you examine, you can find out that they are palpable purpura, and also they are complaints of joint pain and tharish tools. That is, there is some GI symptoms. So what is being asked? It is not the diagnosis which is being asked. It is the investigation and its finding which are basically tested. So in options, IgA deposition, dermal papilla, linear IG along basement membrane zone, perivascular IgA deposition, and none of them. So here I hope you are able to come to a diagnosis which is Henoch-Schönlein purpura. And please remember, Henoch-Schönlein purpura is a small vessel vasculitis. So as you all know, it is a small vessel vasculitis. So the answer here would be, and also HSP, that is Henoch-Schönlein purpura, is also known as IgA vasculitis. In the Rook's textbook, it is mentioned as a separate chapter, IgA vasculitis. So here the answer will be IgA deposition, which is there in all the options. But please remember, it is perivascular deposition of IgA, which is seen in the case of Henoch-Schönlein purpura. And for your reference, I am telling IgA deposition in the dermal papilla is characteristic finding seen in dermatitis herpetiformis. So please remember, this is a vesiculobullous disorder which is having intense itching, and also there will IgA deposition in the dermal papilla. And in the case of linear IG along the basement membrane zone, this particular finding is characteristic for bullous pemphigoid. So please remember, these also are important from exam point of view. So coming to Henoch-Schönlein purpura proper, as I have already told, it's also called IgA vasculitis, and there are so many other names. This is from the Rook's textbook of dermatology. It is also known as anaphylactoid purpura, rheumatoid purpura, allergic purpura, purpura hemorrhagica, non-thrombocytopenic purpura. It is non-thrombocytopenic. Please remember this point. This is important because always remember thrombocytopenia. Thrombocytopenia will cause non-palpable purpura. But as you remember, the question asked for palpable purpura, so this was a clue. So this means that there are other entities which can cause palpable purpura, and please remember, it is vasculitis, and in particular it is small vessel vasculitis which can cause palpable purpura. So this is a very important point from exam point of view. So, and what are the findings which you can see in Henoch-Schönlein purpura? You can remember it with the help of the name itself. H stands for hematuria. P stands for, of course, it is palpable purpura. And S stands for, as I have already mentioned, small vessel vasculitis. And Henoch-Schönlein purpura is basically a tetrad. So as you can see, it's a tetrad. So what are the classical features of this tetrad? I will mention. Presence of renal disease, that is hematuria, and presence of palpable purpura is one of the part of the tetrad, and the other ones are abdominal pain, or you can say any form of GI abnormalities. Like in this question, tarry stools was given, and the other one which is associated with Henoch-Schönlein purpura is arthralgia. So the joint pains also is given in the question. So here the answer is Henoch-Schönlein purpura, and please remember, it is perivascular IgE deposition which is seen in the case of direct immunofluorescence finding of Henoch-Schönlein purpura. So I hope it is clear for everyone. If you are having any queries, please do ask in the comment section, or you can join my Telegram group and you can ask your queries there. Coming to the next question, please try to answer this question. You pause yourself and try to answer this question. Here I am going to explain it as a flow. So what is the question saying? This was a NEETPG 2020 exam question. A child presents with scaly dry skin since birth. Please remember, it is seen since birth. And it is mentioned in the question that colloidal membrane was present. So what is the diagnosis? This was a question, and the image was not given, but in the future they can just show you the image, and they need not even mention that it is colloidal membrane which is present. So with this clue that it is present since birth, you need to understand that it is colloidal membrane. So how does it present? It is like this: dry scales. If the membrane is removed, then you can see underlying erythema which is present, which you are able to clearly see. And in this particular picture, you are also able to see one more clue, that it is autosomal recessive congenital ichthyosis. So please remember, colloidal membrane, it is seen in the case of autosomal recessive congenital ichthyosis. So in the following options, it is lamellar ichthyosis, which is the only option which is autosomal recessive. And as you can see, this I have asked on this particular 7th of July, and as you can see, almost 40% of the children have answered, students have answered it as ichthyosis vulgaris. Please remember, it is lamellar ichthyosis. I will just tell you what are all the autosomal recessive. So these are autosomal recessive congenital ichthyosis, and they are lamellar ichthyosis and congenital ichthyosiform erythroderma. Please remember, congenital ichthyosiform erythroderma, it is non-bullous. It is non-bullous. There won't be any presence of bullae or fluid-filled lesions which are more than 0.5 centimeters. So, and also I want you all to remember one more point. Here it is given the first line, unlike for example IV and RX LV. So what are IV and RX LV? They are ichthyosis vulgaris and X-linked ichthyosis. So please remember, ichthyosis vulgaris and X-linked ichthyosis will never present with a colloidal membrane. Colloidal membrane will not be there in the case of ichthyosis vulgaris and X-linked ichthyosis. And as you can see, the two options, ichthyosis vulgaris and X-linked ichthyosis, are ruled out. And any epidermal epidermolysis is not, it's not associated with colloidal membrane. So answer here would become lamellar ichthyosis. But if it's a PGI type of question and congenital ichthyosis of erythroderma, non-bullous form is given, even this will be the answer. So here I want you to just look at few of the important points of ichthyotic disorder. So lamellar ichthyosis, congenital ichthyosis from erythroderma, and congenital self-healing colloidal membrane. Please remember, all of them are autosomal recessive. As I have told, autosomal recessive congenital ichthyosis are associated with the colloidal membrane. As you can see, all of them are associated with colloidal membrane. And this was the one which I have told, bullous form, and it does not have any colloidal membrane. So it is not associated with colloidal membrane. No colloidal membrane. And one more point which I want you to remember, as the question was already asked. So lamellar ichthyosis, congenital ichthyosis of erythroderma, and self-healing colloidal, all of them are associated with mutations in the transglutaminase 1. So can you try to remember what was dermatitis herpetiformis due to? This was a JIPMAR question also. It is due to antibodies against transglutaminase 3. So please remember this point. Here in this case of ichthyosis, it is transglutaminase 1 gene mutations, and dermatitis herpetiformis, it is transglutaminase 3 against which antibodies are produced. So these are some correlational points which you should remember. Okay, and there are certain common features in between lamellar ichthyosis and congenital ichthyosis of erythroderma, which I want you to focus because they are given in the bold here. They are important. That is, heat intolerance will be present, and associated scarring alopecia can be seen in both of them. This can also be given in the question body as a clue. That's it, friends. You need to know this much about this particular condition. And coming to the next question, so please try to answer this question. Do pause the video and try to answer it. This was asked already in my Telegram group, so I am going to discuss it now. So what is the question giving? Erythema with purplish tinge was present over the upper eyelids, and over the shawl area. So this is a very important clue which is given, shawl area. And also there was associated elevation of the serum creatine phosphokinase, and this image is given. So with all these clues, you should come to a diagnosis of dermatomyositis, which is an autoimmune disorder which involves both skin and also muscles, the most importantly proximal muscles. And coming to the other options, if lupus erythematosus were to be the answer, then in the question body they have to mention something about ANA profile, something about other blood investigations, something about the CNS manifestations, and most important is they would also mention about malar rash instead of this rash over the hand. Can you see this erythema present over metacarpophalangeal joints and interphalangeal joints? So they are names given to all of these signs which are seen in the case of dermatomyositis, which is autoimmune disorder. And as you can see, almost 50% of children have answered it as correct, but there was doubt with the lupus erythematosus. But please remember, as I already told, if it has to be lupus erythematosus, some other clues also would be given in the question. And here are all the signs and symptoms which I have already told you that will be mentioned in the case of dermatomyositis. And the erythema of the upper eyelids, it's given a specific name. It's called as heliotrope rash. Heliotrope means helio, sunlight. So sunlight redness. And you can see here shawl sign, that is there is erythema over the upper back. And there is yet another condition, another name given to the finding of erythema over the joints area. It's called Gottron sign. And if associated with erythema, there are also solid raised lesions, that is papules, then we'll call them as Gottron's papules. And there is yet another named sign given in dermatomyositis. It is summit sign, which means that there are ragged cuticles. So please remember, dermatomyositis is associated with ragged cuticles. So in the nails, you can see that the cuticle which are present with the proximal most part covering the nail plate, there will be ragged appearance. So there are certain antibodies which can be tested in the coming future exams. The important ones are anti-Jo1 and anti-Mi2 antibodies.